Mhm. Okay, so start from disease esophagus. First we discuss that what topic we are going to discuss in this lecture. First, that anatomy, physiology of esophagus and relation to other diseases, and some other clinical features, and what are the investigation tools for that disease of that esophagus, and what are the other treatment of benign and malignant diseases in reference to this. So we discussed the surgical anatomy, physiology, symptoms, investigations, congenital lesions, just like tracheoesophageal fistula and atresia, esophageal atresia, foreign bodies, esophageal perforations, gastroesophageal reflux diseases, hiatus hernia, and esophageal motility disorders. Mhm. So the surgical anatomy, the esophagus, you already had I studied in first year that esophagus it is a fibromuscular organ, which is almost 25 centimeter long, and anatomically it can be divided in three parts: cervical part, thoracic part, and abdominal part. So the cervical part is which is from that uh, cricothyroid to the that extending up to that thoracic levels. Okay, so extending from the cricopharyngeal sphincter to the cardiac orifice of the stomach, that is C6 to T11, that is thoracic part, and below this, that is the just below that diaphragm 4 centimeter, it is esophageal part. So we are not going to discuss anatomy in details. Mhm. Okay, so you see that complete 25 centimeter of esophagus is divided into that initial uh, we always take the length from the mouth. So the important thing is that there is four parts of that, not parts, we can say the four area or the four spot are there where there is anatomical narrowing of that esophagus is happening. So why we are discussing this? Because these are the important spots where anything any obstruction in the esophagus can may happen, uh, because that is the these are the four parts. First part, uh, yeah, here in this slide it's little more clear. There is four part. First part, 6 inch from the incisions, from starting part, means from incision teeth to when you move to 6 inch into the esophagus. Then comes to the first part, that is cricothyroid cartilage. So due to this cartilage, esophagus has little bit narrowing that part. This is the narrowest part. You can see in this slide, it is only 14 in diameters. You know that it is a fibromuscular organ, so it has very much stretchability. It can stretch up to 5 times its normal, up to sometimes more than 5 times to the normal diameters. Understand? So it can be stretched very easily, and up to 5 times. So you see, the first part is the where the cricothyroid cartilage means 6 inches from the incisors. Second is the 9 inch from the incisor, which it crosses the aortic arch. So when you can see in the slide, when the aortic arch crosses the esophagus, so it had little bit constructions over the esophagus. So this is the second narrowest part of the esophagus, means the obstruction can happen here also, that is from 9 inch from the incisors. Always the spot is always identify the distance from the incisors, because when we insert something, the tube, either any that endoscope, either anything, any tube, to know the measure where the obstruction, to see the obstruction, then always, that's why we always count the length from the incisors. Third part is the 11 inch from where it crosses the left main bronchus. You know the bronchus, that with trachea divided into bronchus, left bronchus and right bronchus. So this is the part where the left bronchus crosses the esophagus. So this is the third narrowest part of the esophagus. Next and last part of the esophagus, that is the when esophagus enter into the diaphragm and just open into the that cardia of the stomach. So this is the 16 inches from the incisor where it crosses the diaphragm. So 16 inch from the incision. So this is the fourth part where obstruction may happen in the esophagus. So there are four spots in the esophagus that has little bit anatomical narrowing. First 6 inch, second 9 inch, third 11 inch, and fourth 16 inch where it enters into the esophagus, sorry, in the cardia of the stomach. So this is the little bit that cross section of the esophagus. You see this, it's vascular part, and inside there is the mucosa. So here that little bit that there is changes in the lining of that esophagus. Above the diaphragm, there is the esophagus is mucosa is stratified mucosa, and below it's, that is gastric mucosa, columnar epithelium. So here the stratified epithelium changes into the columnar epithelium. So this is the columnar epithelium, that is the junctions, and this is the muscular part. This is considered as the lower esophageal sphincters. So you know the lower esophageal sphincter is not any real sphincter, just is considered at the junction of that Saddam. So this is the part, this is the lower part of the esophagus where it is supposed to be, there is a one sphincter, though this is not a real sphincter, anatomically cannot identified, but it's that fusion of the muscles, so that the lower part of esophagus has action like a sphincter, because it closes itself. So now in the next slide, when we discuss the physiology of the esophagus, so the physiological function of the esophagus is the transfer food from the mouth to the stomach. That's the only functions, but it's complex procedure, because up to the pharynx in the mouth, it's that in the uh, going food inside the esophagus from the pharynx, it is completely a voluntary process. But after that, when the food is inside the esophagus, then it is completely involuntary process. Understand? So it's a combination of that voluntary and involuntary functions. So what happens when the something is somebody is swallowing something? So that's that normal physiology, when, because there is two orifice, here that trachea and the esophagus. So the epiglottis is the function is there when somebody is swallowing something. So that time that trachea should be closed. that avoid the close and that avoids the regurgitation, or that avoid the going the fluid or something food inside the trachea, that may cause the very much irritation. So this is the complete procedure where somebody is swallowing. So at the same time in swallowing, the trachea is closed, and when the somebody is breathing, at that time
Yes.
esophagus is closed. So it's a complex procedures. After that, there is an involuntary peristaltic movement in the body of esophagus when the food enters in the esophagus. Then there is an involuntary movement occurs in the esophagus, and the food is the in the form of the bolus is going downward into the stomach. So there is the that is the lower part of the esophagus, that is the gastroesophageal sphincters or the lower esophageal sphincters. It's the part of the esophagus, and it's very important structures. Though it is not a anatomically defined part, but it is the part which acts like the sphincters. Though there is no real sphincters, but the part is act like a sphincter that is closes just after food delivering of the food from the esophagus into the stomach, and then it close automatically. And sometime when it is not closed properly, then there is a problem that is called the gastroesophageal reflux diseases, because that lower part of the esophagus, that lower esophageal sphincter, if it is not closed properly, so that causes the regurgitation of the gastric content into the esophagus, and that causes the esophagitis and heartburn. So that's why it's a very important structure is always closed. Once they deliver the food into the cardia of the stomach, it will close automatically. And when some food enters in the esophagus, then it relaxes itself, and so that the food is smoothly with the peristaltic movement from the esophagus to the stomach. The food moves through the with the peristaltic movement in the esophagus, and comes into the when comes to the lower part of the esophagus, then the sphincter dilates itself, and the food is delivered into the cardia of the stomach. Okay, so this is the simple physiologic procedures. Now come to the symptoms. What symptoms occurs if somebody has problem in the esophagus? The first and most common feature, that difficulty in the swallowing, that is dysphagia. If somebody has difficulty in swallowing anything, that is called dysphagia. That may be from the solid food, that may be in the later it may occurs in the liquid foods also. So that when somebody is complaining of that dysphagia, you must to rule out the malignancy in the of the esophagus. Second thing, pain and swelling. Pain on swallowing means that is odinophagia. Means if somebody is swallowing anything, and he or she might have pain, that means there is any inflammatory process is going on inside the esophagus. That may be the esophagitis, that may be that may be any injury or the trauma, and that may be due to that ulceration in the esophagus. Understand? So if somebody complaining odonophagia, you must suspect these kind of things. If somebody is complaining the regurgitation or reflux, means somebody that gastric contents come to the mouth or come to the esophagus, and that is called heartburn. You have already that in the Kachikissa, you maybe read that you maybe have known to that amla pitta. So that is the same is some that amla of the is gastric content, that is the acidic in nature, and it's come to the mouth. So that at that time that causes the severe pain and burning sensation in the upper part of the esophagus. So this is common in the gastroesophageal reflux disease. That is the that is the also known as GERD or GORD. So this is the occurs when the lower esophageal sphincter is not closed properly. Either there may be some anatomical defect or some other kind of, just like the hiatus hernia. You may have already discussed the hiatus hernia in the topic of the hernia. Dr. Junita may have told you that is the topic. If she is not discussed, then you just told her. Either we can discuss in later also. It's nothing, just a herniation of that lower part of esophagus or that upper part of the stomach into the esophagus or into the diaphragm upside. So that the kind of shortening occurs in the esophagus, so that the gastric contents repeatedly comes into that esophagus and causes that esophageal irritations and esophageal ulcerations. So that causes the esophagitis, and patients may have that heartburn, odinophagia, and others, the chest pain, heartburn, others also. If somebody has the chest pain, then along with that cardiac pain, you must consider the esophagus is the potential space for any kind of that pathology is going on inside. And other features, just like loss of weight, anemia, cachexia, and changes in the voice, these are other features may be associated with some esophageal diseases, or along with other diseases. If esophagus is involved in that condition, these symptoms may appear in any patient. So next we discuss the what are the investigation technique we have to diagnose any kind of the pathology going on in the esophagus. First and foremost is important thing, that is the radiography. Radiography means that X-rays, but the plain X-ray is not very much means the plain X-ray is little uh, less important than if we do the contrast radiography. Means if we for that any space occupying lesion inside the means if you suspect any lesion, any space occupying lesion inside the esophagus, or you are suspecting that any perforation in the esophagus, then at that point in place of doing a plain X-ray, better to do contrast X-ray. Means just give some radiolucent substance, just like the barium, and after the swallowing this barium, you just take the X-ray. That is called barium swallow. So when you take the X-ray and that content, that barium, where it goes inside, it gives the clear picture of any space occupying lesion or any perforations. After that, CT scan is also is has little more important, because the guy that you know that the esophagus is it is mediastinum structures, especially in the posterior mediastinum structure. So other important structure are nearby, and the heart is there nearby, the lungs are nearby. So any other kind of the pathology occurs in other organs may have correlations with it. So that plain X-ray and CT are important, but nowadays the having that endoscope, that is two type, rigid or flexible esophagoscopy. Means that is endoscope that are rigid and steel, or some flexible. So flexibles are little more important. So this endoscopy, that esophagoscopy has the very important, because it gives the real-time pictures to you and the direct vision to that area. You can easily diagnose the any swelling, you can easily diagnose any lesion, what kind of lesion is there, esophageal varices, is there any ulcers, it means what kind of lesion is the direct vision. So that nowadays, that's why endoscopy is very much common, because it's easily available, and now it's a 10 to 25 minutes procedures, OPD procedures, no need to admit, and very less complications are there. So in spite of this type of the investigations, some endosonography is also there. to know any lesion in the wall of the esophagus or the outside the esophagus, if any lesion is there, so you can do the ultrasonography, that endoscopic ultrasonography. It's also kind of the investigation which is may be used in the diagnosis of the disease of the esophagus. And one other thing, that esophageal manometry, to diagnose the esophageal motility disorders, because sometimes the esophagus have not proper motility, proper not peristalsis. That's why the some other conditions that may happen. So that measuring the pressures in the esophagus peristaltic movement, so that is called esophagus manometry. It is used in some esophageal, if the motility is suspected is not proper, in that case esophageal manometry is advised. And the last one we are going to discuss, the 24 or pH monitoring, means it's not actual investigation for that esophagus, but it's that we are doing the investigation of that secretions of the gastric acid in the stomach. But in the gastroesophageal reflux diseases, we have to measure this 24-hour pH monitoring, to know that what are that amount of that gastric secretions occurs in 24 in the person. Because if somebody is having more gastric secretions, that may have more chance to the reflex of that gastric acid into the esophagus, that causes the gastroesophageal reflux diseases. So that's why in the case of the GERT, suspected GERT, the 24 hours pH monitoring is advised in the patients. So these are few investigation technique which should be advised in the patient of that esophageal disorders. So this is the picture of the barium swallow. The patient has just swallowed that barium, and at the time the picture is taken. So you can see in this picture there is a in the upper part this is dilation, and the lower part this is the constriction of the lumen, that may have any lesion in the esophagus. So that's why this is the picture of the endosonography. This is the kind of the rigid esophagus esophageal esophagoscopy, and this is the kind of that uh, flexible esophagoscopy. So first we are going to discuss that the congenital disorders, that is congenital esophageal atresia. Esophageal atresia means there is absence of the esophagus, or some part of the esophagus is there, but some part of esophagus is not there, is absent. So this is the normal structure of the esophagus. You can see in the picture the normal anatomy of esophagus, and this is the esophagus, and just behind there is a trachea is there, and esophagus now opening into the stomach. But what happens in some congenital conditions, that a proper fusion of that esophagus, lower part of esophagus to the upper part of esophagus is not there, and there is the formation of the fistula, that is tracheoesophageal fistula. So you see there is a 5 type of conditions may occur. First, where the first part of esophagus, upper part of esophagus is there, and the lower part of the esophagus is fused into the trachea. Second part, where second condition, where the atresia with the double fistula, means the esophageal is somewhat upper part of esophagus there, and after that is fused into trachea, and lower part of esophagus is also fused to trachea. Here, the first part of esophagus is open into the trachea, causing the tracheoesophageal fistula, but the lower part is the blindly, and atresia is the closest there. So here the atresia with the proximal fistula. Here the complete atresia means there is no fistula, but there is a atresia. Here there is a fistula, no atresia, but there is a fistula. So these are 5 conditions where atresia, usually the atresia exists along with the tracheoesophageal fistula in most of the cases. So in the 20% of the babies, some other anomalies are also associated, just like congenital heart diseases, imperforated anus, and some other congenital anomalies. Hydromnia is also there. So if you have a baby with a congenital esophageal atresia or the with the tracheoesophageal fistula, you must try to find out some other anomalies in that baby also. What are the clinical features occurs in the case of the congenital esophageal atresia? That is the first thing, the regurgitation means whatever the food is, it is if only atresia there and there is no fistula, then you see there is no feature of the respiratory distress is there initially. Only the feature is that regurgitation of the saliva or whatever saliva secreted in the mouth or whatever the feed you do, that take that baby, that just vomit of that feeding means continuous regurgitation of the dribbling of that saliva and the milk from the mouth continuously. So this is the most earliest sign of the congenital esophageal atresia. Saliva pours out from the mouth almost continuously because whatever the saliva is secreted, it's not going down there because there is the atresia. So that's why it happens. Persistent feeding may cause the aspirations, because if there is, you see any baby has the atresia and mother is continuously feeding that, so what happens now, the esophageal because the esophagus is closed there, so it fills. After that filling, it's now the esophageal contents going to the trachea, that aspirations, and that may cause the choking, cyanosis, and respiratory distress. So it's very dangerous. So very important to diagnose very easily. If early diagnose the case, then you can save the life of baby, and immediate surgery is required in that case. So how can we confirm the diagnosis? The very important, very simple thing is that just take a soft rubber catheter and insert from the esophagus through the mouth. That will not pass beyond 10 centimeters. Means from the lips, if the tube is not passing in the esophagus more than 10 centimeter, it confirms there is the esophageal atresia there. After that, if you for the confirm, that radiological confirmation may be done by the contrast X-ray in little older baby, either in that esophagoscopy or that other procedures that investigation should be taken. So what the treatment? Treatment, so it is the purely surgical treatment should be done immediately. No conservative approach will work here. Head of the baby should keep up to the 30-degree, so that it avoid the regurgitation of the that esophageal content into that trachea, that may avoid that aspirations and that what we call the aspiration and the respiratory distress, and continue and start antibiotic. As you know that the patient may have that if you are suspecting even the esophageal atresia, you must start that antibiotics, because that may cause the later aspiration and causes the pneumonia. So in the proper you start the antibiotics as you suspect the case of the esophageal atresia. Gastrostomy is useful before operative repair of esophagus. It is nothing, just opening of the that lower part of the esophagus or that stomach, and insert a tube, so that you can start the feeding of the baby, and wait for the definite later definitive repair of that esophagus to anastomosis of both part of that esophagus for the atresia. Understand? So this is the procedure which should be done immediately and initially, and later on you can wait for that definitive repair of that esophageal atresia. So that gastrostomy, not gastrotomy. Understand? Gastrostomy, it is the different term. Gastrostomy, where the ostomy is there, it means there is you creating one os, means there is you creating an opening and keeping it, so that is the ostomy. Gastrostomy, you are creating an opening into the that stomach and keep it, and put one catheter or the drain or sometimes some tube there, so you can start feeding of that baby, because the nutrition is also very important. Definitive surgical repair of the tracheoesophageal fistula and end-to-end anastomosis of the both proximal and distal segments. That is the definitive repair. So this is the process of repair. We will discuss in the next lecture.
Sir,
Yes.
the rubber catheter part, sir.
Just you have to insert one rubber catheter inside that mouth of the baby, and if it not cross beyond the 10 centimeter, it means there is a atresia. Means your catheter is not crossing more than 10 centimeter in the mouth of baby. It and you first make sure your catheter is inside the that esophagus, and because if it goes in the trachea, patient may have that baby may have respiratory distress and have some cyanosis and other features of that, and cough also. So if you are inserting your catheter the rubber tube inside the esophagus and your tube is not going beyond the 10 centimeter from the lips, it means uh, that there is no esophagus beyond this. There is atresia, there is close there. Understand? Or your baby is continuously having that dribbling of the saliva and the dribbling of the whatever the milk feed by the baby, continuously regurgitation from the mouth, continuously from that dribbling and baby continues vomit that whatever you feed that is the one sign of, maybe the sign of that esophageal atresia. There means there is a blocking of the esophagus there. If the baby has esophageal means tracheoesophageal fistula, then in that conditions you may find that when you start the feeding, patient may have that baby may have cough, because that contents is going through the trachea and causing the irritations that may lead later on leads to the pneumonia also. Understand?
Sir, thank you, sir.
Okay. So how many of you? 27. Okay. So I'm taking class from the home, so that's why there no register here. So okay, so we will discuss the next part in the next lecture. Okay.
सर
Sir,
Yes, bolo.
सर ये एंडोसोनोग्राफी जो पिक्चर जो आपने दिखाया था सर, सर वो नॉर्मल या एब्नॉर्मल है वो पता नहीं चल रहा था, मतलब कैसे पहचानेगा?
वो एक्चुअली देखो, इंडोसोनोग्राफी तो मैंने भी नहीं देखी कहीं, लेकिन उसमें कुछ लीजन होगा, वो नॉर्मल ही है, नॉर्मल है। क्योंकि सोनोग्राफी किस बेसिस पे काम करता है हमारा, कि व्हाट एवर दैट दैट मींस homologous or heterologous, means what kind of tissue is there. If the same tissue is there, then there is no finding. If that consistency of tissue is changed, then there is a lesion there. So that was the normal, I think.
Okay sir.
You all know the principle of that radiography, that principle of that on which principle X-ray is working, on which principle that ultrasonography is working. You know that your principle is clear or not?
सर इतना अच्छा से नहीं आता सर।
क्यों, आप लोगों का सेकेंड ईयर में क्लास हुआ होगा ना रेडियोलॉजी ये सब चीज का, तो ओके हम किसी दिन बात कर लेंगे इस पे, कोई प्रॉब्लम नहीं है, ठीक है।
ये बेरियम सर, इसमें जो बेरियम
सोलो,
बेरियम मील और सर बेरियम सोलो जैसे एक ही है ना सर?
नहीं देखिए, बेरियम मील एक होता है, बेरियम सोलो, बेरियम फॉलो थ्रू, दैट डिफरेंट थिंग्स। बेरियम सोलो मींस वी जस्ट you ask that patient to take the barium, at the same time you take the picture. So you see that soloing for that upper esophagus, pharynx, and if there is any obstruction is there, and the solo and barium follow through means you just ask the patient to take that barium, and after a few minutes you take that when that barium goes to the stomach. After a few minutes and hours you take that when the barium goes to the next part, duodenum, esophagus, jejunum, ileum, then colon. Understand means you follow the barium, wherever the barium go, you start taking the picture. So at the different intervals, so you have the clear idea of that complete alimentary canal. If there is any obstruction is there, then you can see there is then narrowing, or if any the dilation is there, you can see that. Barium meal also kind of means you ask to patient the take, and you take the picture after that. Means if you are suspecting any obstruction in the esophagus, then you have to take immediately. If you are suspecting any obstruction in the colon, then you have to wait for that barium will reach the colon, then you take the picture. That is the barium meal.
सर अगर कोलन रिलेटेड अगर देखना हो तो बेरियम मील वाला सर
हाँ, उसमें लेट ही, क्योंकि तुरंत पहुंचेगा नहीं ना. If you ask the patient to take, then it will take time to go to the up to the duodenum. Sorry, that colon.